ASAM conference in April, and I was asked to present something that I attended there that I thought was helpful and interesting. And on the last day, there was a group of lectures about physician well-being and addictions in physicians. They're focused primarily on physicians, but the whole healthcare workforce and our colleagues being affected by addictions. So that's what I'm going to talk about, give you some of the information they shared. How do we move forward with the slides?
You just let me know.
Okay. So some of the things I'm going to talk about is what impairment is secondary to addictions and other causes. Discuss physician health programs, which are programs available for physicians who are affected by addictions in their work. The role of state medical boards. Describe what addictions are like among physicians. Describe interventions in cases of suspected impairment. Discuss outcomes for physicians with addiction, and discuss legal aspects of physician impairment. And this translates really to all disciplines in healthcare, not just physicians, but the focus of the talk that I attended was on physicians. Next slide, please. So a lot of people may be affected by addictions, and some very important clinicians in history have been affected by addictions and psychiatric disorders. And so here's some examples. Sigmund Freud had cocaine use disorder and depression. Dr. Bob, the co-founder of Alcoholics Anonymous with Bill W., had an alcohol use disorder. Ignaz Semmelweis had alcohol use disorder and depression. He was a pioneer of antiseptic procedures. William Halsted, the famous surgeon at Johns Hopkins, had cocaine and opiate use disorders. And Oliver Sacks, the well-known author, neurologist, had depression and amphetamine use disorder. So these are just some examples of how really prominent people in the field can be affected by addiction and psychiatric disorders. Next slide. So just to give you a sense of how common psychiatric and addictive disorders are, in general, about 1 in 4 people age 18 and older have a mental disorder in any given year, and almost half of people will have a mental disorder in their lifetime. That's according to this one study, but they're very prevalent, and something like 43.7 million people in the United States had a diagnosable condition according to SAMHSA. And an interesting thing about these statistics is that the rate of illness is probably underestimated because of stigma. And so people tend to conceal the fact that they have an illness. And so the rates are probably even higher. So vulnerability to mental illness is a real big problem in this world. And physicians develop mental health problems at the same rates as the general population. Addictive disorders is a little bit different, and I'll get to that. And we're talking about $200 billion a year in the United States as the cost of mental disorders, and that exceeds heart disease, stroke, and even cancer. Next slide. So unfortunately, some people are affected by addictions in their work, and it leads to behaviors and syndromes that compromise the ability to practice safely and responsibly as a clinician. But unfortunately, there's no clearly well-defined demarcating like red line about when someone's impaired. It's a judgment call. And so it's a hazy kind of an area, but a very critical area in healthcare. Next slide. So what are some causes of impairment? Well, you can have medical causes like dementia and delirium, and then psychiatric causes like mood disorders, psychotic disorders, anxiety disorders, substance use disorders, and characterological problems like antisocial personality disorder. Next slide. Now also, physician burnout is very common, and this is common in all members of the healthcare workforce. So about 50% of people are struggling with burnout. And there's kind of 3 major domains of burnout: exhaustion, cynicism, and feeling ineffective. And while burnout affects the individual, the cause of burnout is really the system. So it involves, first of all, workflow, And that can be the medical record, the computerized medical records that we use, and other aspects of workflow. And also loneliness is becoming a more and more of a problem for clinicians in their practice of medicine and psychiatry and addictions. So we live in a society in the West where rugged individualism is emphasized, as opposed to in the East where there's more collectivist culture. And so some people enjoy solitude, but unfortunately it can lead to burnout when people struggle with loneliness. And so we want to enhance connection and have a diverse, inclusive environment. And so, like I said, physicians experience the effects of burnout both in their professional lives and their personal lives. And this can lead to depression, substance abuse, unprofessional behavior, and medical errors. Next slide. So one problem that we have with physicians that may be different from other healthcare providers is that they don't tend to seek medical care. And so you might wonder, why would that be? Somebody who's actually providing care doesn't seek it for themselves. But there are some problems that arise in physicians' practice that can kind of impede the self-care that needs to take place. And so one thing is that they may not have someone to back them up to take time off. And also they may feel that they don't have this time in their schedule to allow for getting the medical care that they need. And unfortunately, the people who most need help are the least likely to get it. And so also another issue is that physicians may worry about what will happen to their practice if they seek care. Will it affect malpractice insurance? Will it affect their licensure? So there are some consequences in some cases of practitioners revealing that they have an illness that requires medical care. Next slide. So what kind of behaviors come to the attention of the licensing board? So some of these are kind of obvious problems, like physicians physically or sexually abusing a patient, or prescribing drugs in excessive amounts without a legitimate reason, and then impaired ability to practice due to addiction, medical illness, or mental illness, being dishonest, criminal convictions, not recognizing or acting on a common symptom, and failing to complete continuing education requirements. But the point here is that when something comes to the licensing board's attention, it may be just an isolated incident, or it may be actually the tip of an iceberg. And so they will get involved in an investigation to see, is this person having a lot of difficulties with their practice, and is this a serious problem that needs to be addressed? Next slide. So some states, this talk that I attended at ASAM was in San Diego. So the laws that they talked about were in California. And I'm actually not positive what the laws are in West Virginia, but some states require that physicians who witness a colleague acting in an impaired way in their practice have to be reported by the clinician who recognizes it. And there'll be consequences to the clinician for failing to report someone's impairment. And when I got my position at WVU, there was talk about that in the paperwork that I did with the application, that we were required to report if someone appeared impaired due to addictions or other reasons. Now, physician health matters are dealt with separately from disciplinary matters and are handled with a confidential, treatment-focused, rehabilitative philosophy. And disciplinary consequences depend on how serious the offending behavior is. Next slide. Now, there are physician health programs in almost every state, and these programs are designed to assist people physicians who are having problems with their practice, secondary to health-related problems. And unfortunately, for some clinicians, when you come to the attention of the health program, they may feel that the assessment that's done is more thorough and more costly than they desired, but it is in the best interest of many parties who are going to be affected by a clinician who may be impaired. So some of the things that can happen: a physician may have to be chaperoned for their examinations or performing procedures. They may need a fitness of duty evaluation for approval of return to work. They may have random office visits to assess record keeping. They may be subject to random drug testing, and that can be in urine, blood, saliva, or hair. And typically with physician health programs, physicians are monitored for a period of 5 years. Next slide. So like I was saying, the prevalence rate of addiction among physicians is different than the general population. So in the physicians, it's about 7.9%, in the general population, 13%. And another thing that's different is the kind of substances that physicians tend to use, and I'll get into more detail, but the physicians are more likely to use sedatives and opiates and drink more alcohol. And the rate of male to female physicians who are affected by addiction is about 7 to 1. So much more of a testosterone problem. And female physicians are still more likely to have alcohol-related problems in the general population and are more likely to have psychiatric disorders as well. Next slide. So the majority of medical board disciplinary actions are drug and alcohol related, and it's about 14 to 21% of them. Next slide. So an interesting thing that they shared in this talk was which kind of physicians are most likely to be affected by substance use disorders. And there's 3 areas of medicine that are most affected: psychiatrists, anesthesiologists, and emergency medicine physicians. And they didn't have an explanation for why that is exactly. With the exception of anesthesiologists, there's something interesting about their work that may set them up for having trouble. And I'll get more into that. And then the lowest rates are surgeons, pathologists, and pediatricians. Next slide. So like I said, alcohol is the most commonly used substance when both among physicians and the general population, but then prescribed medications are more likely as opposed to illicit drugs in the general population. And so physicians may use nicotine, opiates, benzodiazepines. You can see marijuana, cocaine, and even propofol. You think of Michael Jackson's physician getting involved with the use of that. All right, next slide. So what are the risk factors for addiction among physicians? Family history is the strongest predictive factor, and 22% of physicians have a family history of alcohol dependence. Also, personality factors like sensation seeking, drug access, of course, physicians and other medical practitioners have more drug access. Stress drives something called self-medication. Kansian had a self-medication hypothesis about why people use substances. And then the priming effects of the drug itself. And then microdosing of anesthesiologists in the OR. So one addiction specialist was walking along the beach and he could smell the salt in the air as he was walking along the beach. And he started to think, maybe anesthesiologists in the OR are experiencing exposure to the drugs that are used during surgery because they're kind of low doses in the air as they're working. And so that they think that might be the reason why anesthesiologists get into trouble. Next slide.
I've never heard that.
So what are the warning signs of substance use in physicians? Disturbance in family and social functioning, domestic problems, appearance of being intoxicated at social functions, an odor of alcohol at work or signs of intoxication, irregular hours for rounds, self-prescribing, neglect of responsibilities, anger outbursts, frequent medical complaints without a reasonable diagnosis, and staff concerns about physician behavior, depression or weight change, and DUI or DWI convictions or citations. Next slide. So interventions for physicians who are affected by addiction, a comprehensive evaluation is necessary. And what happens is that the doctor is removed from his work role to a center with expertise. And there they undergo neuropsychological testing and psychological testing and family assessment and collateral information from coworkers and hospital employees and friends and even the physician health program. Previous records are reviewed, and then they use a chain of custody for the drug screening so that there's no likelihood that the sample has been tainted or affected by someone else, that it goes directly from the patient to the lab. Next slide. So the goal of intervening with a physician or any clinician who's been impaired by substance use is to detect a problem that leads to impairment early and intervene before they damage their careers or harm patients. And in general, what the purpose is to gently coerce them rather than referring them to the medical board or possible legal action. So we try to encourage people to get help before consequences get involved. Next slide. So physicians are encouraged to attend treatment programs for a longer period than the general population who are affected by addictions. And the purpose of that is that the longer the period of treatment, the better platform they have for recovery. And physician health programs will advocate for a clinician if they're doing well in treatment. Next slide. So there's a whole bunch of monitoring that goes on: weekly group therapy, support groups, aftercare groups, individual and family therapy, mutual support groups, drug testing, and like I said, the worksite monitoring is typically for 5 years. Next slide. So one thing about medication-assisted treatment in physicians, none of the physician health programs in the United States allow physicians to be treated with Suboxone for opiate addiction. They have to be on Vivitrol. There is one exception to that, and that's when a physician has a chronic pain condition that can't be treated without opiates, and then they may approve the physician being treated with Suboxone. There's no science to support this kind of attitude. I attended another lecture where they compared naltrexone to Suboxone to see if there was a difference in outcomes. And part of the measures was cognitive functioning in comparing Suboxone-treated patients from naltrexone, from Vivitrol-treated patients. And there was no difference in functioning or cognitive abilities. So there's no real scientific reason for not allowing Suboxone in physicians who have opiate use disorder. And then you can see the other approaches to treatment. One thing, leverage is super important in physicians. You know, physicians have so much to lose that there's a lot of, and all healthcare providers are really that way. You know, that if they love their careers, they're going to be pretty motivated. Plus, they've invested a lot of money and schooling in their education for their careers, and they're not likely to make bad choices because the powerful leverage that's placed upon them. Next slide. So of course, level of care is based upon needs, and if someone's failing a given level of care, then you want to intensify the treatment. With physicians who are affected by addictions, the escalating up the levels of care is much more rapid because of the potential consequences of an impaired physician. Next slide. So what are some of the relapse factors? Negative emotions, stress, overwhelming complexity, interpersonal conflict, social pressure, conditioned craving, a lack of satiety, and mental fatigue can all contribute to relapse. Next slide. And I'm not sure where this slide comes from. I can't remember where I got it from, but it's an interesting slide showing that in the general population, chronic illnesses of other types have the same kind of rates of relapse as drug addiction. So 40 to 60% for drug addiction, diabetes, hypertension, and asthma kind of fall in the same sort of areas. So, you know, drug addiction is a chronic illness and outcomes are similar. However, if you look at the next slide, physicians have incredible abstinence rates. And for studies extending over 21 years, there's a 65 to 91% abstinence rate. So physicians make good patients in the addictions field, and outcomes are good. And I've had limited exposure to working with physicians. I've had a couple patients that I've worked with in Maryland when I was practicing there. But I've had a lot of experience working with nurses and nurse assistants and other disciplines in the medical field. And I think this rings true for all of healthcare, that the leverage is pretty powerful, but it's most powerful in physicians, I think. So problems with behavioral adherence to the monitoring requirements commonly precede substance use. So if the physician health program notices that somebody's not following the requirements of their program, they're going to be alerted that this may be an indication that something is going awry. And then physicians who have trouble maintaining abstinence should be removed from the workforce until they are deemed appropriate to return to work. And like I said, licensure leverage is a powerful motivator. Next slide. So one big problem with physicians and being impaired by addictions is the question, do we discipline doctors or do we need to rehabilitate them? And the answer is it really needs to be tailored to the case. Some physicians have such egregious behavior that, legal criminal actions need to be taken against them, whereas other clinicians are more just appropriately treated in a rehabilitative approach. So physicians who have addictions face trouble with stigma, shame, and guilt. There's a lot of stakeholders who are interested in the health of the whole healthcare workforce. But for physicians, it's malpractice insurers, state medical boards, specialty boards, patient insurers, and employers and patients. And getting help early from a physician health program can help avoid things coming to the attention of the state medical board. Next slide. So the last talk that was part of this collection of talks on physician health was about the legal aspects of an investigation. And an important thing these are all kind of important things to know if you ever are investigated for something like this. The investigation will be reported to the National Practitioner Data Bank. And so that would affect all future employment because all employers have access to the National Practitioner Data Bank. And if an investigation is being done, don't just walk away when they start to look into it. You need to, if you leave then and separate, then your right to contest it disappears. And they highly recommend that you seek legal counsel. There's lawyers who are well experienced with dealing with these sorts of cases and know what you need to do to protect yourself, and how they can work well with you to defend your position with the medical board. Now, there is no physician-patient privilege in medical board or criminal cases, so your evaluation by a psychiatrist or addiction specialist is going to be available to the medical board. And the process can be fair. That's what they said. I guess that's true. Next slide. So this is my last slide. Charles Munger was the partner of Warren Buffett. I guess that they're old, but they still work together, I think. And he's a pretty wise individual. So I really like what he said about addiction. You guys can tell me what you think of this. He says, while susceptibility varies, addiction can happen to any of us through a subtle process where the bonds of degradation are too light to be felt until they are too strong to be broken. And yet, I have yet to meet anyone in over 6 decades of life whose life was worsened by fear and avoidance of such a deceptive pathway to destruction. One should stay far away from any conduct at all likely to drift into chemical dependency. Even a small chance of suffering so great a damage should be avoided. All right, thank you.
Excellent. Thank you so much, Dr. Hirschler.
Thank you, Dr. Hirschler.
Great. Are there any questions?
Why isn't subcutaneous naloxone, buprenorphine allowed for opiate addiction?
It's a good question. I'm just telling you what the physician health program's policy is, and maybe it will change as the science kind of, argues so strongly that they're making an erroneous decision. But it does seem, like Sublocade obviously would seem like an appropriate treatment.
Yep.
Yeah.
Thanks.
I know that's the same case for the nursing, the West Virginia Restored Nursing Monitoring Program in the state too, that they will not allow their participants to be on Suboxone. And I attempted to try to discuss that on a phone call once, and it was not up for discussion.
Any clue at all about why they are against Suboxone on that phone call, or they just wouldn't even give you a reason?
Didn't really get a reason. The impression I got was just that's the way it's been, so that's the way it is. You know, I agree with Dr. Hirschler. My hope is that when more and more evidence gets talked about in the medical field, that maybe eventually, sooner than later, they'll change that. I think they're doing a disservice to their folks by not letting it be an option.
It's also a good way to do a sort of a minimal clinical trial. I mean, we don't have enough data yet. It'd be a good way to get some data started.
Oh, good point. Yeah.
All right. Are there any other questions? All right. Excellent. Thank you so much, Dr. Hirschler.
You're welcome.
Great. So Dr. Green, are you ready if I share your case to present?
Yes, I'm ready.
Awesome.
Okay. And I have some updates since I submitted this. So basically this is a patient that's been in our program about 4 weeks, and my questions are just any suggestions regarding how to proceed with his management. He is probably one of the most complex patients that we have admitted to our program out here at Sissonville, because of his, as you can see, because of his long history of trauma, incarceration, long history of addiction. He also has some literacy issues. So this is a 49-year-old male who has a history of substance use since around age 8 years old. He was recruited kind of into our program through our staff that works at the health department. At one point, as I understand it, he and his significant other were homeless, and they were able to kind of get some housing for him and do some some motivational interviewing and things, and then he decided that he was ready to seek treatment. He expresses a really high level of motivation. He's, with this long history of abuse, he repeatedly will say, "I'm done with that. I have done that before. If I wanted to go back to that, I would. But I want this recovery for myself." And he's also highly motivated to be into recovery because of his young grandkids as well. He reported a history of hepatitis B and C. This was initially when he had his initial labs to come into the program. His acute hepatitis A antibody was also positive. We did some further investigating and think maybe he had a mild, subacute, that was kind of a subacute hepatitis A virus, but liver enzymes were fine at that time. So we think maybe he was lucky. So his substance use history started at 8 with cocaine and marijuana, opioids, then progressed to heroin more recently. He had a history of IV use. He also used marijuana and methamphetamines pretty frequently. He had never been in any kind of a treatment program. He said the only sobriety he had were some periods of time when he was incarcerated for 13 years, but even during his incarceration, he continued to use. His social support, he identifies his wife as his strong social support. She also assists him with the literacy issues as well. Like I said, from my understanding, they were homeless at once, but they do now have housing that's close here to our office. He utilizes public transportation, the city bus. He does have a relationship with his adult children and his grandchildren that seems to be pretty good. And like I said, a real motivator are those young grandchildren. He had less than an 8th grade education. He has carpentry skills, a family history of substance and alcohol use. He admitted a prior suicide attempt and was hospitalized for that, but then reported that he never followed up and never had any other than that episode, denied any other psychiatric history until he got into the program. And then we found out that it sounds like that at different times, at various times, providers have attempted to treat him with a variety of antidepressant medicines. Dr. Carter evaluated him for opioid use, stimulant use, cannabis use disorder, depression, anxiety, and possible PTSD. So he, like I said, he has been in our program about 4 weeks. A couple of the things that he struggled with, he has struggled with providing the urine drug screens in a timely manner, and he relates this, and he seems frustrated by it himself, but relates it to that long history of incarceration, and he's only allowed to use the bathroom at certain times of day, and he has some trouble with that. But no behaviors reported from the staff that would indicate he's trying to hide anything when he does give his urine for the drug screens. He struggled with going to 12-step meetings. He seemed to, after the first few weeks, his mood seemed to get kind of labile, and he would be tearful frequently during group, and he had continued the urine drug screens continued to be positive for marijuana and methamphetamine. Finally, because we have a delay in receiving our results, we finally got the results back this past Wednesday for like October 3rd and 10th, and the confirmatory tests on the marijuana did show a decrease in the marijuana use, which he had said that he was weaning down, and then he had denied any use for the week prior. But then he had denied any methamphetamine use for about 3 weeks, and yet those confirmatory tests came back and were positive for methamphetamine. He also struggled with some pretty severe headaches once starting on Suboxone. We encouraged him about drinking fluids. The other group members encouraged him about, that these usually get better. And he ended up seeing his primary care for kind of the mood issues and the headaches. But I think, as I understand it, when they tried to put him on medicine, that's when he started saying, well, I've tried several medicines before for depression. So at this point, week before last, Dr. Carter and I pulled him out of the group at that point, and this was before we got those confirmatory tests back, but just for the labile mood, we pulled him out and said, hey, are you still comfortable participating in the group setting? We're happy to pull you out and see you individually. And at that point, he had really started to bond with some of the group members and wanted to stay in there. And we were just checking in with him to make sure he was comfortable. So then fast forward to this past week, he continued to have the headaches, depressed mood, and then the positive drug screens. So I actually talked after Josh had a session with him. Oh, and that's one thing we had done is he had been doing weekly individual BH sessions with Josh. And he had seen him last Monday after that session because he was complaining the headaches were so bad that it was actually causing him to consider dropping out of the program and using. And so I talked to Dr. Berry, and he has suggested that we try Remeron for a number of reasons. Number one, thinking that because he complained about not sleeping well, that maybe that would help the sleep, which would help the headaches, would help the mood, and potentially have some benefit for methamphetamine cravings, although he had continued to deny the methamphetamine use. So before group started last week, we brought him, Lois and myself and Josh saw him. We explained to him that we felt like, that he needed a higher level of care. So we pulled him out of the group setting and we're seeing him 3 days a week, continuing the weekly BH visit. Josh talked to him about a psychiatry referral, but he has trust issues, and he would only he will only see a psychiatrist that works closely with Josh, that Josh can talk to, and so and vouch for. And so we're in the process. We have a psychiatrist that just started, and she's hasn't started yet seeing patients, but he has agreed to allow us to refer him to her. But in the meantime, we talked to him about starting the Remeron, a low dose of the Remeron. And so he overall accepted the plan last week. He was a little frustrated by, I think, not, being pulled out of the group because he had started to bond with the group members, and a little frustrated by not getting a full prescription. And so then when he came in on Friday for his check-in, he had a relapse on methamphetamine, a reported relapse on methamphetamine and marijuana. I was
going to say that was following, on Wednesday after group, he got news that he had hepatitis A, B, and C. So he didn't go home that day. He just kind of stayed out on the street, went and used. He didn't want to go tell his wife that he had all three of those. He was kind of looking at it as like a death sentence, which Lois and I addressed on Friday, talked to him about treatments, management, all that kind of stuff.
Okay.
So.
And so he came back in today. He denied any further relapse over the weekend. He said that he was even faced with, he found some heroin, but that he got rid of it. He had, and that was the other thing, since we're seeing him 3 times a week here, and to try to kind of work him back up into some structure, and he's seeing Josh once a week, we decreased his 12-step meetings to 2 a week. So he does 2 of those and is here at the office 3 times a week with 1 session with Josh. And so he did say that he has a plan now. He found a meeting that he can go to on Wednesdays and Thursdays, so we'll see how that goes. He continued to have some, again, today he had issues, providing a urine sample. It took a while, and some coffee and water and that kind of thing, which he is frustrated by as well. I think that's kind of it.
Yeah, I think the big thing on my end I'm trying to rule out is rolling out PTSD versus potential psychosis. First, it seemed PTSD related because it started back up, or at least he started reporting it after he had some sobriety under his belt. It seemed like more intrusive thoughts. He said he could hear his mother and his stepfather, which were the perpetrators of the majority of the abuse he experienced growing up, which it almost seemed like re-experiencing. Like he was just thinking a lot about that. But then I was in session, a PCP was seeing him for potential SSRIs, and they pulled me in because he was saying he was hearing voices, and I figured it was just the intrusive thoughts. Got some more information, and he was hearing their voices, supposedly, with current issues. So like they were telling him in that moment he really wanted to go use. So I'm trying to figure out if he was hearing voices or he was thinking it, because they were telling him that he needed to choke me out and go use. So, which he said he wouldn't do because he trusted me and respected me. So he was like kind of denying the voices in that way. So I'm just trying to rule those out, and that's why I really want to get him in to see a psychiatrist.
Gosh, first of all, I want to say he's clearly at the right place. For him to only be with you guys for 4 weeks and have developed this much trust in you, and if he's been using for 40 years and this is his first treatment experience, I can't imagine how overwhelmed he feels by the process, and that he's able to trust you guys so quickly. I'm just so glad he's with you guys.
He's definitely grown to trust us a lot very quickly. And the only way we got that trust, he was going to the health department for about 6 months, and we have a psychologist there, Dr. Van Horn, who built a huge relationship with him and basically vouched for me to get him to come see me for an intake. Yeah. And that's why he wants me to vouch for the psychiatrist.
Oh, that's awesome.
Was the trauma as a child and while he's incarcerated, or separate?
He's starting to talk a little more about trauma while incarcerated. He was talking about some potential sexual assault today. So,
but it was also as a child.
As a child too.
So,
There's physical, emotional, and sexual abuse within the household. He talked multiple times about being pulled out of bed and basically beaten until he couldn't walk, witnessing his sisters being raped by the stepfather, and his multiple things. His Brother was shot and killed in front of him when he was 7. Just all kinds of traumatic events. Like, it's more, like, I get more every time I see him. Like, it's when you think there can't be anything else that happened.
Right.
Yeah. Well, it sounds like he's getting the message from you guys, you know, his difficulty in producing urine. It, you know, I'm guessing he's not getting any kind of like stress or pressure from you guys. You know, he knows it's kind of an expectation, but, you know, but it sounds like you're doing a wonderful job of like giving him extra fluids and giving him time. And, you know, it's not like he's got 15 minutes to do it. He can sort of have his whole clinic time, and maybe that's helping de-stress it for him.
And the big thing we've been trying to do is to address things in a different way, just because his only experiences with authority have been his parents and incarceration.
Yeah.
And seeing us as an authority figure, he would not be here very long.
Yeah. Yeah. I'm not sure I know. So what are your specific questions?
Because I agree with Katie that you're doing great things right now. It's amazing getting him to open up at his time, at his, you know, his ability to do that. And we're going to see a lot of relapses till a lot more things come out, obviously. But just having him in that setting with you, and then the psychiatry referral, knock on wood, he'll maintain that appointment, individual counseling. And then can you have the groups also and still come to you more often?
Be in our group visits.
Yeah.
Our concern with that was because he is so fragile, like confronting him in front of the group, we weren't sure how he would take that.
Sure.
We just didn't feel like that. I mean, that
right.
with how fragile he is, that he would, you know, be able to.
The other thing was just his history of physical violence.
Right.
And he's very, very sensitive to perceived disrespect and will act violently very quickly on that.
Okay.
So it's been, just trying to get it. We haven't had any issues with it. There's been a couple times where like a patient's passed him in the hall and like maybe accidentally brushed against him, and it actually happened today and he said something under his breath, but he didn't do anything. So I think the big thing is just trying to gauge and get him comfortable with it. But the group was very helpful. One of the psychotherapy groups, 2 of the longer term patients actually talked him through. He had a gram of heroin in his dresser drawer trying to test himself, and they talked him into getting rid of that by the end of the group.
Oh, awesome. I love the power of a group.
Because you were talking about that bonding within the group, which sounded fantastic. But I also share your concern about that. Yeah, the violence. Yeah, I definitely share that concern.
Yeah, because I was trying to get there with him, but he was getting a little defensive, but the group got him there much more quickly than I ever could.
Yeah.
It's just, I mean, it seemed like it would be better to put him back in the group once he can kind of conform to the requirements of the program, because it just felt like we were setting him up for defeat. And most of we have a small group, but a lot of them have we have several bi-weekly people. So these are people that are not relapsing frequently. So we thought this was going to make him feel, you know, like he is struggling as compared to them, but there was no one else kind of at his level.
Sure.
It's the big thing is that as we keep going with, because there's going to be more relapses more than likely, is the biggest thing just like kind of taking that harm reduction approach, keeping him in. Okay.
Right.
Yeah, I think from just a safety perspective, and then in the process of helping him build more confidence in himself and continued more trust in you guys, you know, then it's some points, you know, kind of moving over from the harm reduction to abstinence, because it sounds like that's what he wants, his goal. You know, he's very motivated for that.
How old are his grandkids, by the way? I'm just curious, because that was a motivating factor. His grandkids.
9, 7, and 5.
Because that's another big factor all over the state, trying to destigmatize illiteracy too. If we can really help him understand that he can learn a lot from his grandkids too, with iPads and all this technology out there, that may be a great confidence builder. confidence builder for him to actually. He's really still young in my opinion, but he's 49. I'm 51, of course. but just to have him at that confidence booster, just because he has that motivating factor for them too. That may be something to kind of see if there's any literacy programs around or with the schools.
That's a great idea.
Yeah, he really talks all the time about not wanting to be nodding off to sleep, intoxicated around his grandkids, right. And he wants them, he kind of relives his own, childhood through their joy in, having what sounds like, a very different childhood than his own childhood was.
Right.
One of his big goals is, like you mentioned, like learning to read so he can read them a story.
Yeah.
Oh, I love it.
Yeah,
that's fantastic. Yeah. I mean, Remeron's a great idea, but then I'm sure more things will come out, like you said, when the trauma stories come out. Don't want to over-medicate, obviously. But.
Yeah, I'm hoping between me and the psychiatrist we can get it managed.
Right.
Just with the integrated primary care side, we can't really do traditional therapy. At some point, I may have to refer him out, but I hope I can build up a good enough relationship where I can refer him out for traditional trauma treatment if he needs that in the future.
Yeah, I think the plan that you guys came up with, patient, is excellent. I was actually able to meet this patient while I was down there visiting and he is a very complex patient. So I think the 3 days a week, the 2 meetings, I think that's an excellent plan for him. And hopefully that will be able to get him on track enough eventually to where he can go back into the group therapy session.
That I think that, it's good that he participated in that group, and so that does give him something to look forward to versus had he ever started not in the group, he wouldn't have known, So I think that will help to motivate him to.
Right. Yeah, he can actually look at it as like the graduation process that we have, where you graduate from a weekly group into a bi-weekly group and a bi-weekly group to a monthly group and so forth. So he's being seen basically individually. It might be 3 days a week, but he's being seen individually. So once he successfully completes that, he can graduate into a weekly group. Another way that you could look at it too.
Well, great. Thank you so much. Do you guys have any other questions, or does anybody else have any other questions about this?
I'm just curious what WVU's got for their harm reduction approach right now. I think you have like an IMAT protocol or an ICODE protocol, right? And but there's no actual harm reduction protocol existing up there, right?
So ultimately, that's in terms of like the therapeutic approach. That's sometimes what we're taking in our AP code or our ICODE program, and AP code's twice a week, and ICODE's 3 days a week. In those groups, in terms of what we're doing in group therapy, is just kind of ultimately figuring out where the patient's at, what their goals are at, and talking harm reduction approach from a medical standpoint. I'll let Dr. Hirschler or Dr. Chandran answer that.
With his hepatitis treatments, that'll be another issue too, obviously. But definitely, as long as you have a comprehensive team approach, like you're bringing up with the psychiatrist, primary care, GI specialist for the hepatitis treatments, those will be all big factors. And like you mentioned before, just knowing that he's going to relapse, if he can just maintain that honesty that he's using and tell us up front, hey, I'm using. I think that'll be the approach that we all take. I think with our ARCO clinics. With education, the marijuana doesn't seem like he's going to stop the marijuana, does it?
It actually that I don't know if I mentioned that, but on the marijuana levels have trended down.
Okay, yeah.
So, yeah.
Okay.
That's great.
Yeah, we do have a 3-day-a-week program as well that Dr. Morrison had mentioned, which is our ICODE program, our intensive code program, which is very similar to what you guys have set up for this patient. Mondays is the therapy portion, Wednesdays is med management,
right.
And then Fridays they meet with a recovery coach / case manager, and they talk about relapse prevention meetings and things like that. This group was developed for patients that struggle in the COPE clinic. It goes into our advanced probationary 2 days a week clinic and then still struggle in that clinic as well. So we put them into the ICODE. They're typically in there for approximately 30 to 60 days being evaluated to see if they're appropriate to go back into either the advanced probationary COPE clinic or the regular COPE clinic. If at that time that we see that they're not going to be successful, then we'll actually refer them out to like a daily check-in, methadone clinic, 28-day program, something like that.
When your patients are coming to the 3-day-a-week program, do they provide a urine sample at all of those visits?
Originally, I believe that we did.
And then it got super expensive. I think some of the insurances.
Medicaid would not pay for all of those. Prior authorizations became an issue, so I think we cut back on the random drug screens. However, I believe we still do have them fill out the usage form at each one of those appointments.
Okay.
We actually we collect it and then we just check it once a week to kind of work around that problem. Mm-hmm. We don't tell them which day we're actually checking it, or we make them think we're checking it every day.
Oh, so you collect it each visit and then just like have it hang out in a fridge somewhere? Is that what?
Exactly. I just dump it out right away if we know we're not going to check it that day. We don't show them that we're doing that. It's all part of the trick to try to keep them on it.
That's smart.
Yeah, turkey.
Yeah. All right.
Great. Everybody's learning a little bit from everybody else.
Exactly.
Yeah, absolutely.
Wonderful. Well, Dr. Green and Dr. Carter, I did want to just let you know if you ever want to, I'm sure a PCP can do it too, but we do have the Hep C echo sessions that you're welcome to attend for this patient. We have a great infectious disease team that would be happy to talk about him too. And they of course will make recommendations for A, B, C, HIV, anything else.
Thank you.
Yeah. All right. Any other questions, anybody, in our last 2 minutes?
Yes. When you, this is for Douglas, he said that when they kind of get to a certain point in ICODE that you refer out to a methadone program, is that something that you just like give them the information and say, sorry, not working here, but here's your referral to the local methadone program? Or you actually like take the time to get an appointment set up for those folks, because that can be difficult for us.
Right. So I don't think that we would just give a patient a taper script and say refer to a methadone clinic and then them not be able to get into that clinic for 2 months or something like that. I would assume that we would hold that patient until they can get into that clinic.
Okay.
Good question.
All right. Great. Well, I will, of course, send out the reminder. If anybody has any cases, please feel free to turn those in to me. I'm not sure of the date of our next meeting, but of course, I'll let you know. And then I will let you know, too, getting closer to the holidays, if we run into any blocks or if anybody's not going to be here, just let me know, and we can definitely postpone and reschedule a couple of things if we ever need to. But everybody have a wonderful day.
Thank you.
Thanks. Thank you.
Thank you all so much. Thank you.